This conference will now be recorded.
All right, let's cover Chapter 8, Pathophysiology. Some of the notes I want to bring up as well that I have for this. Perfect. All right, so this really integrates comprehensive knowledge of the pathophysiology of the major human systems. So things we're going to be kind of what we talked about in the last class. I know that was very, very long. And I would like to kind of go over that chapter again more towards the end of the program to get you guys ready for your national. We do have some extra days planned for like sick days if I'm like sick and can't get an instructor to come in. So I want to kind of go over that stuff again with you guys, kind of hit more towards the end of the chapter and a recap on chapter 7. That's a lot of information we did in 4 hours. So to answer your question, Matt, are you by a computer? If you are Harrington, yeah. Can you just put in the chat box the name of that app again? Kenny was looking for it.
Yeah, I'm working on it.
Awesome, thank you.
Yep.
All right, let's continue on with this here then when we're doing that. So a pathophysiology is a study of physiology of altered functioning in the presence of a disease, something that we may have. So like when the body can no longer maintain homeostasis, the disease may result in something. So when the body can no longer meet that even playing ground, what's actually going on in their system. So you must understand the ways disease alters the structure and the function of the cells. Everything breaks down to that cellular level, and the medications that we're giving go down to that level to help maintain homeostasis of a patient, whether that be utilizing fluids, to antiemetics, to nitrates, to whatever we're going to be administering to these patients, generally goes down to that cellular level to kind of help maintain that. We keep using the word homeostasis a lot, but homeostasis of the body. So with this adaptation in the cells and tissues, so when exposed to an adverse condition, cells undergo a process of adaptation. We have atrophy, hypertrophy, hyperplasia, dysplasia, metaplasia. We'll kind of go over those a little more in detail. So atrophy is a decrease in a cell size due to the loss of a subcellular component. Hypertrophy is the increase in the size of a cell due to synthesis of more subcellular components. Hyperplasia is increased in the actual number of cells in an organ or tissue. Dysplasia is an alteration of the size, shape, and organization of that cell. And metaplasia is reversible cellular adaptation in which one adult cell type is replaced by another. So with this disturbances in fluid balance, right, and this is where we start seeing patients have cardiac dysrhythmias, to heart failure, to any other kind of disease that's out there. We start having a disturbance in some type of fluid balance somewhere within the system. So remember that the human body is composed primarily of water, right? So with that being said, changes in any kind of fluid or electrolyte balance that disrupts homeostasis can either cause or exacerbate various disease processes. So with that being said, homeostasis can be upset in several different ways, such as excessive output or input of fluids, which is why it's very important that we measure how much fluid is going in a patient. We don't want to cause fluid overload. We also don't want to have too little amount of fluid coming in, because that can cause the patient to become more dehydrated. We're not getting enough fluids in at all. We also want to make sure we're looking at the excessive output of fluid, whether it be through a wound, blood leaking out for hypovolemia, or the fact that we have excessive vomiting, diarrhea, things like that. We also got to look at the amount of fluid coming out with urination. And are they on medications that increase that urination output, like Lasix, being a loop diuretic, right? So there's a lot of different factors that go into this based on medications patients take to help alter the body to help meet homeostasis. Does that make sense, everybody? Good? Okay. I don't want to lose anybody in this one here. Awesome, awesome. All right. So we measure everything that we do from neonates to adults. We have to measure fluid input. All right, I'm going to give you guys some numbers. These are things that are not on the slides. These are more realistic numbers we have to follow. A neonate receives 10 milliliters of fluid per kilogram. I know we've covered this before. A pediatric is 20 milliliters of fluid per kilogram. All right, and a adult receives 30 milliliters per kilogram. And we administer these medications in a bolus. And this is where people start getting confused. Bolus versus fluid challenge. All right, when we're starting to meet that, I'm putting this stuff more in the real world stuff now as far as patient care goes compared to disturbance in fluid balance. What is the difference in your eyes? All right, thanks, Jen. What is the difference in your eyes between a fluid challenge and a fluid bolus? What are your thoughts?
Oh,
Is a
bolus.
fluid bolus like a one-shot thing, and then a fluid challenge would be like continuous fluids?
I'm going to give you half credit for that. All right. How would you administer a fluid bolus?
Intravenously?
Okay. Now let's take it. Okay, we got IV intravenous. Thank you. Let's go one step above that. Is it administered through a drip set, through a bag of fluid running, or is it administered through a syringe?
Wouldn't it
Syringe.
be
Someone else is talking also.
wouldn't it be titrated?
Good question. Is it titrated? So that's what we're talking about. When is the difference? When do we give a challenge to a patient to see if we have a change or an effect versus actually giving a fluid bolus where we want to have that effect? And I'll give you an example. A patient with a patient with hypotension. I'm talking blood, was an adult male, blood pressures, let's say 70 over 30. They got a map in the 50s. Okay. This patient needs a fluid bolus, not a challenge, right? So if we're going to administer a fluid bolus, we're going to take and use a syringe. We're going to pull back a 60 ml syringe, 100 ml syringe, whatever it may be, and we're going to push that fluid in hopes that we have a change in that blood pressure. That's called a bolus. And then we push, IV push, pushing in. Everybody thinks that a fluid bolus is just opening a drip set, a 15 drop set, wide open. That's a challenge. That's a fluid challenge. That's what we're going to be doing to see if we can maintain that homeostasis. And once we get that set up, then we do something called TKO, or to keep open, and we run a saline drip or a lactated ringer's drip or a D5 drip, whatever it may be. And that's when we start getting into more pump therapy, right? Where they can say, okay, now we've done that bolus, met that challenge. Now what we want to do is maintain it through IV pump therapy at 150 mLs an hour. All right, does that make sense?
So wouldn't you titrate to effect?
Yes, you would titrate the bolus to meet the effect you're looking for. That's increase in blood pressure. Correct. So that's what we're looking for with the bolus, challenge, and then maintenance. So bolus, challenge, and maintenance drips. So a degree of fluid imbalance required to compromise homeostasis and cause illness depends on the patient's age, their size of the patient, and underlying medical conditions. Also, fluid therapy is a fundamental step in resuscitation, which we just talked about, right? So we're looking at the underlying conditions. What are their underlying conditions? How do we find out? Questioning, sample history, getting that detailed history of what's wrong with your patient, right? the size of the patient, okay? If you weigh 300 pounds, right? You put that into kilograms, 300 divided by 2 is 150. Take off 15 is 135. So you have a 135 kilogram patient. Multiply someone do the math for me. 135 times 30. What do you guys got?
4,050.
Okay. That's how much fluid this patient should be getting. I'm not saying you need to bolus that medication, but that's going to be your fluid challenge on administration to meet that homeostasis. So you can bolus, let's say 300, 400 mLs to see if you meet that effect you're looking for blood pressure increase. Give them that fluid challenge. And if you can maintain it, then we maintain it at like 125, 150 mLs an hour. Take that same patient who weighs 120 pounds, right? So you take 120 divided by 2 is 60, minus 6 is 54, right? So the patient weighs 54 kilos, multiply that by 30 for the adult, and that's going to be your fluid challenge. Did I lose anybody yet on the math?
Yeah, why did you multiply it by 30?
So that's what you're looking at, is the 30 mLs per kilo is your adult dosing for fluid administration.
Okay, I got it.
Yep. Now, if it was a pediatric, then it would be 20 mLs per kilo. And if it was a neonate, so newborn to 30 days, would be 10 mLs per kilo.
Got it, okay.
Because you don't want to give a neonate 30 mLs per kilo because you'll fluid overload and kill him. Right? So we want to make sure we hold that.
We don't want to do that.
We don't. That's why it's so important. And when we get into pediatrics, we'll talk more about how to use three-way stopcocks and be able to pulling fluid out and administering through bolus and syringe. Because it's way easier to do that than it is running a bag wide open and then saying, oops, I guess I forgot, I got carried away. Next thing you know, you dump a liter of fluid into a 3-day-old. You know, that's something you don't want to do to meet that challenge. Thanks, Matt, for putting that up. Now, other disturbances in fluid balances would be swelling caused by excessive fluid trapped in the body's tissue. Remember the interstitial fluid we talked about before in AEMT? This is interstitial space right here. This is fluid buildup, what they call edema. Okay, this is fluid trapped in that third spacing, they call it, or interstitial space. That usually means what? Why would this be happening? And yes, this is an increased capillary hydrostatic pressure, is what you're seeing. But why is this happening? Give me some examples. Okay, cells overloaded. Let's go a little more in depth. Let's find out some diagnoses here. What can cause increased capillary hydrostatic pressure?
Excess sodium.
Yeah, excess sodium. And I'm glad you brought that up because we're going to be discussing this here very shortly on sodium. So diabetes may or may not cause that. Hypertension, yep. Diabetes will cause more than neuropathy, and you will have some fluid buildup as well from that. What else?
CHF.
Okay, we'll talk about CHF. That's congestive heart failure. Specifically, let's break it down into the advanced level now. Specifically, more what side, right or left? Perfect. Right-sided heart failure, exactly. Other things that could cause would be allergic reactions or inflammation, right? Urticaria allergic reaction. Venous obstruction, pregnancy, heat stress as well. These are other things that could cause increased swelling. Even trauma can cause bleeding or swelling in that area as well. Maybe not so much full leg edema, but more localized in like the ankle, if you roll an ankle and things like that. But again, increased capillary hydrostatic pressure. Now, we can also have decreased colloidal osmotic pressure in capillaries, which is decreased production of plasma proteins in the patients with liver disease or severe protein deficiency. Increased loss of plasma proteins from kidney disease or extensive burns can also cause edema. Other things that you can look for as well will be obstruction in the lymphatic vessels. So the clinical manifestations of the edema may be local or generalized. In-depth physical assessment, okay, and this is very important for us moving up our. All right, Jen, I'll see you when you come back. What's really important for us to understand in the physical assessment is we got to take that next step. We got to move into that advanced level of care, right? So we're going to auscultate breath sounds, but not just looking at breath sounds at the front, right? We're doing 6 different locations on the back, 4 different locations on the front, and we're going to be listening. And I'll show you guys more of that assessment on the 30th when we have our in-person day. We're going to do evaluation for pedal and sacral edema and jugular vein distension. Okay. We're going to do evaluation of vital signs. And the thing with all this is definitive treatment depends on the underlying medical condition that's there, right? We're not going to start giving nitrates to a patient who has fluid in their legs. But if they listen to lung sounds and you have an overabundance of fluid, acute pulmonary edema in their lungs, then we're going to start thinking about CPAP and nitrates, right? If you hear wheezing, but the lungs are full of fluid, and you give somebody albuterol and you cause a sympathomimetic response, what can happen to the patient's lungs? What would happen to the patient's lungs in a person in pulmonary edema when you gave them albuterol?
Take on more fluid.
Big flash.
Yeah, take on more fluid. Flash, adds more, yeah. And we're going to drown our patient, right? This is why it's so important to get that detailed assessment, get that really good medical history, because that's going to help determine our treatment plan. Looking at differential diagnosis to come up with a good plan to treat this patient. Right? We also have what they call the isotonic fluid deficit. With this, it's decreased extracellular fluid with proportionate losses of sodium and water. This is the most common form of fluid loss. Isotonic fluid excess in a proportionate increase of sodium and water in the extracellular fluid. The common cause include kidney and heart failure. The average adult urinates 30 mLs an hour. That's if you had a Foley catheter in place, you should be putting out at minimum 30 mLs an hour. Anything less than that, then we have something wrong with the kidneys. Why are they not working? Right? And that goes back into more testing to see if they're in kidney failure. And one of some of the lab values to look at for that one would be creatinine and then the BUN and the creatinine, those two that we look at. And that will give us a GFR number as well to see how well their glomerulus are filtrating. So we look at a bunch of different numbers looking at lab values to see if this patient's in true kidney failure. So let's talk about some electrolyte imbalances, because we deal a lot with this, and a lot of this stuff here can actually cause more damage to the patient. All right, let's talk about sodium. So sodium regulates fluid balance, total fluid volume, and blood pressure in the human body. It also facilitates muscle contraction and nerve impulse transmissions. Hypertonic fluid deficit occurs due to a disproportionate loss of sodium during water loss. So when would you have significant water loss? Sweating, yes. Let's find something else. Our body can usually compensate for sweating. Sweating only. Now you start adding heat into that, that's different. Now let's start talking vomiting. Excessive vomiting, right? What else?
Uncontrolled diabetes.
Yep.
Diarrhea.
What else? Diarrhea. So if you take and put this into perspective, okay? 2 cans of soda is the entire blood volume of a 1-year-old, neonate pediatric. babies. So if you have excessive bouts of diarrhea and excessive vomiting in a pediatric, can they become dehydrated quickly? Yes. Everybody should be saying yes, absolutely. If we have a loss in sodium, what do you think can happen? People should just say death, pretty much, right? What's going to happen is the patient's going to have cardiac arrhythmias, right? So hypernatremia, okay, Na, sodium, is a serum sodium level of greater than 146 milliequivalents per liter, okay? Some numbers you might want to memorize. You'll probably see this on an exam. Hypernatremia, serum sodium level of 146 or higher is the patient's hypernatremic. Hyponatremia is a serum level of 134 or less. So causes of hyper or hyponatremia include excessive sweating and heat or during exercise, gastrointestinal loss through vomiting and diarrhea, and inappropriate use of intravenous fluids or diuretics. Okay? We cannot give diuretics in the field, okay, not as AEMTs. Okay? However, we do administer IV fluids. And what is the main component, of sodium chloride? So, sodium, right? Normal saline, main component is sodium. So what happens if we fluid overload somebody and give them too much sodium? What would happen?
Cause heart arrhythmias.
Yeah, heart arrhythmias is a big one, right? Also, more fluid retention because now they have an abundance of sodium in the system. You see how important it is to make sure you know the numbers when you're administering fluid. Yeah, like Tondra just said, fluid buildup. Absolutely. Right? That's why it's very important to make sure you look at your own sodium intake as well. Another part of sodium is your sodium potassium pump. And now that we're getting into that, which helps run the heart electrically to function. So let's talk about potassium. Potassium is crucial to many cellular functions. The normal serum level of potassium ranges from 3.5 to 5 milliequivalents per liter. Hypokalemia, right, or hypo-K, is a decreased serum potassium level. Causes include decreased dietary potassium intake and absorption, decreased shift of potassium into the cells, renal potassium loss, extrarenal potassium loss as well. Hyperkalemia is an elevated serum level, remember to be greater than 5. Causes include decreased excretion, shifts of potassium from within the cells, or excessive dietary potassium intake. So I know this is a little above and beyond, but I want to give you guys a little bit more with this. If a patient is hyperkalemic, so high potassium, if you do a 12 lead EKG, the T wave, and we'll go over all this during cardiology, but you'll see a very peaked T wave. If a patient is hypokalemic, so low sodium, less than 3.5, all right, you'll see a T wave that is flat, not rounded, but flattened. And that would be an indication on a 12 lead the patient has high or low potassium. Now let's take this one step further. It's very important to understand what patients take for meds. All right. What is furosemide?
Water pill.
A water
Lasix.
pill. Lasix. Yep. And what is one of the big components of I should say components. What is one of the bigger mechanism of actions with Lasix?
Increased urinary output, isn't it?
Increase urinary output, and also is noted as a non-potassium sparing diuretic. So if somebody overdoses because they took their Monday morning pills too many times and they have dementia, and they take triple the amount of Lasix, and they piss out all their potassium, what's going to happen?
They'll die.
They can. They're going to go into definitely go into some cardiac arrhythmias, and we have to fix that problem. Now, we carry a medication on the ambulance at the AEMT level called Ringer's lactate. Ringer's lactate has sodium, potassium, magnesium. It has all these different electrolytes in them. The problem behind that, and this is why it's very important, is to know how much fluid you're giving. Because if you fluid overload somebody with too much electrolyte, you're going to take them out of homeostasis, and you're going to put them into more lethal rhythm. That's why you hear a lot, why do AEMTs and paramedics have lactated ringers? That's why. It's a very dangerous med, but also a very great medication for dehydration, for patients that are bleeding out, things like that, because it flows with blood better than saline does. Any patient that goes to an OR, coming out of an ER, going to the OR, always has a liter of ringers running before they go in, all the time. All right. So these are just things to think about now that we're moving up levels, understanding everything goes down to that cellular level, and we have to understand electrolytes, because if we do something wrong, it causes more detrimental injury to the patient. All right, calcium. The normal serum level is 8.6 to 10.2 milligrams per deciliter. Hypocalcemia is a decreased level. Hypercalcemia is increased. Nearly all, which is 98%, is found in the bones and teeth. This lends strength and stability to the collagen around the substance that forms the matrix of the skeletal system. It enters the body through the gastrointestinal tract. Remember that the normal levels are 8.6 to 10.2, and hypocalcemia is a decreased level. Some causes include the following: decreased calcium intake or absorption, increased calcium loss, endocrine disease, and sepsis. Hypercalcemia is increased serum level caused by increased calcium intake or absorption, endocrine disorders, neoplasms, and other different causes that are out there, more of a miscellaneous cause. Right? A lot of times we'll see patients with low calcium. So once again, this is why they keep saying in septic patients, lactated ringers is a great medication, because not only are you not making urine, you're dehydrated, your sodium levels are going to be low, your potassium is probably going to be low, your calcium is probably going to be low because you're septic. But you don't want to give too much either, right? That's why they're saying that ringers is actually a better medication. They're also, and I just listened to a podcast on this just recently, is they're actually saying that hypertonic fluids are actually a lot better for that as well, because we don't want to cause fluid overload. Septic patients are getting on an average of 6 to 8 liters of fluid. Now, where you give someone a hypertonic saline, you could actually decrease that by 5 or 6 liters, and it still maintains the same amount of fluid, just less going in. It holds better. So this illustration here shows the regulation of blood calcium level. And to be honest with you, it's very tiny on my screen. I can't even see it. So if you guys can see that, great. We'll definitely cover more of this as well when we get into practical scenarios and how to be able to recognize certain things. All right, the next electrolyte we're going to talk about is phosphate. So phosphate, primarily as an intracellular anion, essential to maintain body functions. Hypophosphatemia is a decreased level in serum phosphate caused by decreased supply or absorption, excessive loss of phosphate associated with the use of diuretics or in patients with hyperthyroidism or alcoholism. Intracellular shift of phosphorus, electrolyte abnormalities, or abnormal loss of nutrients followed by inadequate replenishment. Right? Hyperphosphatemia is increased level of serum phosphate caused by massive loading of phosphate into the extracellular fluid or decreased excretion into the urine. These are all things that we cannot test in the field. What they're going to do is they're going to do a CMP, which is a comprehensive metabolic panel, and it's based on the labs that we draw. That's why it's so important to get lab work drawn in the field, because when you put the IV in place and draw your rainbow labs, this is all part of it. It does a complete blood count, comprehensive metabolic panel, gets all your LFTs, liver functions. It gets your troponins for cardiac enzymes. They can run a lot of stuff off the stuff that we draw in the field. All right. That's why it's so important to get these lab draws, because in the hospital, they may have to stick the patient a second time. Our job is to do no harm, and that actually harms the patient the more times they stick. On top of that, you're also putting another line of potential infection. So if we can get labs on our initial lines as AEMTs, let's get them. Now, I'm not saying that you don't, I'm not saying on a critical patient you grab labs and say, hold up, I know I need to shock you, but we're going to hold off for a minute because I got to grab labs. When it's feasible to grab them, then grab them. Magnesium. 50% of this is stored in the bones, and the 49% in other body cells, and there's 1% in extracellular fluid. The normal range of magnesium is 1.6 to 2.6 milliequivalents per liter. Hypomagnesia is a decreased level of serum magnesium caused by diminished magnesium absorption or intake, increased renal loss of magnesium, or miscellaneous causes such as diabetes, respiratory alkalosis, or pregnancy. Interesting that you bring up pregnancy, right? I'm drawing a blank, my goodness. What would happen, or what does it mean when a patient is eclamptic, pregnancy patient? Not pre-eclampsia, but eclampsia.
Increased blood pressure.
That would be more the pre-eclamptic. If they're eclamptic, what happens? What do they start doing? This is a basic EMT question. When a patient
Seizures.
is eclamptic, seizures, exactly. And the cure for that is getting a paramedic on board, because what's happening is their body has low magnesium. So they're going to get mag sulfate as a medication. That is the treatment for seizures in pregnant patients, because they have low magnesium. Hypermagnesemia is increased level of serum magnesium. Almost always occurs as a result of kidney insufficiency. All right. And then if you look at table 8.2 in your books, right, the major electrolytes of the body are summarized. So we take all of this stuff that we just learned, right? And we look at this, disturbance of acid-base balance. So pH is a measure of the acidity or alkalinity of a solution. The lower the pH, the higher the acidity. So acidosis is an increase in extracellular hydrogen ions. Alkalosis is a decrease in extracellular hydrogen ions. So with this, disturbances of acid-base balance are associated with disturbances of potassium balance. One of the things I want you guys to look up, not right now, kind of like a homework assignment. Take a look at this right here, the tic-tac-toe method of acid-base balance. They can give you long formulas.
Kevin,
But if
I
you
gotta
can
go.
All right.
I'll
If
see
you
you in a
can
bit.
measure, yep, sounds good. Thanks, Matt.
Yep, bye.
If you look at the tic-tac-toe method of acid-base balance, you literally can teach this to a firefighter with no EMS background, and they can have an understanding of how to tell if the patient is respiratory acidosis or alkalosis or metabolic acidosis or alkalosis, memorizing different values: pH, end tidal, and bicarb. So respiratory acidosis is related to hypoventilation, right? Causes would be airway obstruction, cardiac arrest, overdose on a central nervous system depressant drug like heroin, submersion, respiratory arrest, pulmonary edema, closed head injury, and chest trauma. The signs and symptoms of respiratory acidosis include systemic or cerebral vasodilation, headache and lightheadedness, warm flushed skin, CNS depression, slow respiratory rate, nausea and vomiting. These are all signs and symptoms and causes of respiratory acidosis. When you start getting an end tidal CO2 readings, it will make a world of a difference. And I have another lecture that I utilize and I teach quite often on end tidal, and it will change your entire world and how you think about treating patients, including head traumas and things like that, as well as dealing with respiratory alkalosis and acidosis. Now we're going to fix it in the field, even at the advanced level. Remember that in New Hampshire, since this is a New Hampshire class, you can utilize waveform capnography as an EMT. Respiratory alkalosis is associated with the conditions that result in hyperventilation. All right. So if you have a patient who is hyperventilating, would you expect to see elevated carbon dioxide or decreased carbon dioxide?
Increased?
Nope, not increased. It must be the other one. You'll see you'll see a decrease in end tidal in patients that are hyperventilating, right? If they're hyperventilating, they're not blowing off enough carbon dioxide, right? If you're hypoventilating, can't get it out. If you're hypoventilating, you're going to see an increase in end tidal. So now I have to tell you the ranges. The normal range of end tidal CO2 is 35 to 45. Okay? So you're going to see numbers less than 35 on patients that are hyperventilating. Let me put this into perspective with a patient care now. A patient who is septic, okay, will have an increased respiratory rate and a decreased end tidal. Imagine that. Two indicators that we look for: respiratory rate of greater than 24, end tidal less than 32, are two indicators of severe inflammatory response syndrome where the known or presumed infection site is sepsis. We did diagnosis based on looking at numbers and waveform. Numbers and waveform, right? There are other indicators as well, but those are two of the major ones. Right? Am I losing anybody yet? Everybody good? Okay. So some signs, and well, before we get to that, hyperventilation accompanied by cardopedal spasm is a classic sign of respiratory alkalosis. A patient's hyperventilating, they can't off gas, they're retaining it, right? Like Kobe just mentioned in the chat group, they're taking it in, they're not expelling enough back out. Therefore, causes carpal and pedal spasming, So that cramping and curling of the fingers, that's when we start to see that. Causes include drug overdose, fever, overzealous bag valve mask ventilation. Signs and symptoms include diminished level of consciousness, lightheadedness, cardiopetal spasm, chest tightness, confusion, vertigo, blurred vision, and nausea, vomiting. Metabolic acidosis is any acidosis unrelated to the respiratory system. Excuse me. Causes would include lactic acidosis, ketoacidosis, aspirin overdose, excessive alcohol ingestion, so alcoholic ketoacidosis, gastrointestinal losses, carbon monoxide poisoning. Signs and symptoms would be vasodilation, CNS suppression, headaches, warm flushed skin, tachypnea, nausea, vomiting, cardiac dysrhythmias. Right? That's metabolic acidosis. Metabolic alkalosis occurs due to an excessive loss of acid, rarely an acute condition, but common among chronically ill patients. So we don't usually see a lot of metabolic alkalosis. Usually we see a metabolic acidosis, right? So a patient that's in cardiac arrest, like I said, are going to be patients that are going to be in metabolic and respiratory alkalotic issues. So some common causes of metabolic alkalosis is excessive vomiting, excessive water intake, nasogastric suctioning, excessive intake of alkaline substances. That's why it's very important to understand your toxidromes and understand the toxins people are taking in. So if they intake an alkaline substance, it's going to put them in a metabolic alkalosis. Signs and symptoms would be confusion, decreased respiratory rate, muscle tremors and cramps, and hypotension. All right. Any questions on the alkalosis and acidosis of respiratory and metabolic? Everybody good with those? I'm putting down some values in here. I want you guys to take note. That's your pH normal range. End title. Who's unmuted right now? Oh, Kenny is. All right. Thanks, Kenny. All right. End title 35 to 45. And your HCO3 is 22 to 26, which is, that's not it, BICARB, bicarb. HCO3 is bicarb. Those are going to be your normal values. pH 7.35 to 7.45. Our body runs a little alkalotic. End title of 35 to 45 normal range, bicarb 22 to 26. Anything above 45, or anything above 7.45 is alkalotic, right? Anything above 45 would be alkalotic on end title, lower is acidotic. HCO3 bicarb is anything higher than 26 is alkalotic, less than 22 is acidotic. With that being said, it is a pH imbalance of 7.56 with an end title of 55. They're in respiratory alkalosis. So we got to look at the tic-tac-toe board, and you'll be able to put those in. If you draw a tic-tac-toe board right now, and you put acid on the top one, the middle one is neutral, and the or normal, I should say, not neutral, but normal, and the other side on the right is alkalotic, and you put the numbers in those. that you have in front of you based upon what you see for values, and you do tic-tac-toe 3 in a row, and that tells you whether or not it's respiratory or metabolic, acidosis or alkalosis. Anything with a bicarb deficiency, or it's going to be metabolic. Anything with end-tidal issues is respiratory. Does that make sense? Without actually having a tic-tac-toe board in front of me, it's hard for me to show you. Any questions on that? I'm seeing a bunch of no's pop up. All right, thank you. All right, good. All right, so let's talk about cellular injury. So there are various processes may cause cellular injury: hypoxia, lack of oxygen; ischemia, lack of blood supply; chemical injury; infectious injury; immunologic hypersensitivity injury; physical damage, mechanical injury; or inflammatory injury, right? So we can talk about blood supply ischemia, right? The lack of blood, whether it be a clot somewhere to you bleeding out for hypovolemic, lack of blood supply somewhere in the system. Hypoxia, that could be from a pulmonary embolus to COVID to pneumonia to whatever, any kind of disease process, right? Infectious injuries, again, same thing. Like sepsis could be an infectious injury causing cellular injury as well. Immunologic hypersensitivity, physical damage, mechanical. That could be as simple as a crush injury causing cellular damage, and that can cause a lot of issues with crush injury and release of lactic acid in the system, right? We also have inflammatory injuries as well. Any kind of like anaphylactic reaction or allergic reaction can cause inflammatory problems. So manifestations of cellular injury occur at the microscopic, structural, and functional level, as you can see here in the pictures. So the common microscopic abnormality include cell swelling, rupture of the cell membrane or nuclear membrane, or a breakdown of the nuclear material such as chromosomes. Functional disturbances may also include inefficient oxygen utilization, intracellular acidosis, toxic waste accumulation, dearrangement of nutrient metabolization, and any dysfunction in one system inevitably affects the function of other systems as well. So cellular injury can also be repaired up to a point with proper treatment. That's why it's important to be able to pick up on these types of injuries. So let's talk more about hypoxic. So the common and most often deadly cause of cellular injury is hypoxic injury, which may result from decreased amounts of oxygen in the air, loss of hemoglobin function, decreased number of red blood cells, a disease of the respiratory or cardiovascular system. Right? So to look at red blood cells, platelet counts, hematocrit hemoglobin checks, these are all done through lab testing. And the lab testing panel that they're going to do this with is called a CBC, or a complete blood count. Cells that are hypoxic more than a few seconds produce mediators, which lead to more cell damage. Right? This is a result of free radicals that are the earliest and most dangerous mediators produced by a cell. Right? We start seeing this, we start seeing death in a patient. Chemical injury is a variety of chemicals that may inquire and ultimately destroy cells. The common poisons include cyanide and pesticides. Huh. Interesting, right? Cyanide and pesticides. How can we tell if there's cyanide? What does cyanide smell like?
Almond.
Almonds, right? Interesting that only 50% of the population can smell almonds. Here's something for you to try. Get a bag, get a plastic bag, you put some almonds in it, and try smelling it. Let me know if you can smell it. It's a good class project. You have 15 students in the class. Let's see if half. See if you can break the 50%. But it smells like almonds. How do we know if somebody has been infected with pesticides? All right. So Matt, you mentioned sludgeum. What is sludgeum? I'm not sure if Matt, you're
How on
typing it.
earth does Kenny become unmuted every time? All I can hear is him.
I'm not really sure how that happens. Of course, actually, be hitting the button. I've done that before. All right. So sludgeum. What is sludgeum? Anybody know? It's a toxidrome. Each letter means something. It's okay, Kenny. No worries. All right, that's fair, Matt. So let's go through all of them really quick.
Salivation.
Yep, go ahead.
I can't remember what L is. Urination, defecation. As far as I can remember.
Okay, so we'll do salivation, lacrimation, so tear ducts, right? We have urination, defecation, GI, gastric, emesis, and meiosis. Another acronym that you can utilize through this would be dumbbells or sludge. I mean, they've had 3 different ones that have been out there over the years, right? So that's going to be a toxidrome in toxicology. We're going to cover more of that in detail, but that's your pesticide. So cyanide includes cell hypoxia, and pesticides prevent proper transmission of nerve impulses by blocking the enzyme called acetylcholinesterase. So ACH, acetylcholinesterase. Long-term ingestion of lead also leads to brain injury and neurologic dysfunction. Carbon monoxide prevents adequate oxygenation of the tissue, and higher doses of ethanol produce severe CNS depression and hypoventilation. So patients that have carbon monoxide poisoning, if you put them on a pulse oximetry, you're going to get inaccurate readings. You might read 100% because carbon monoxide has a higher affinity, which makes it attached to the red blood cells over oxygen. Now, with that being said, pulse oximetry only reads molecules that are based on red blood cells. It doesn't know the difference between the two. That's why you need a RAD57 or SPCO to measure the amount of carbon monoxide in the system. As far as pesticides, you're going to see patients have a significant bradycardia as well. In order to treat this, in order to treat your pesticide, is going to be something called a Mark 1 kit, or what they which is 2-PAM and atropine being administered. New Hampshire required that in the trucks years ago as a mandate that was funded by the state. They said, here are your kits, but you have to buy new ones on your own when they expire. Well, no one bought them because they are very, very expensive. And they kept them on the trucks, but they were only supposed to be utilized for you and your partner only, not for patient use. And not a lot of EMS services even carry enough atropine to be able to treat this. You're looking at 6 to 8 milligrams of atropine to treat a patient with pesticide issue. Organophosphate. I should be more towards organophosphate than pesticide, but the same thing. There are other pesticides out there. They're not going to have the sludgeum. That's more of organophosphate. All right, moving forward. Infectious injury occurs as a result of an invasion of bacteria, fungi, or virus. which measures the virulence and measures the disease causing the ability of a microorganism. A depressed immune system is less capable of fighting off microorganisms. So what we usually check for those as part of your CVC count is going to be your white count to see if you have any way to fight off. Elevated white counts mean there's an infection. If you have a very low white count, that means you can't fight anything off. A lot of times you'll see that with patients that are immunocompromised. So when cells are injured, circulating white blood cells are attracted to the site of the injury and release endogenous pyrogens, which cause a fever to develop. The fever is a good thing, all right, because it's helping fight that infection. However, it also can dehydrate you and then can cause sepsis, which is a systemic disease caused by the proliferation of microorganisms or related toxins in the blood. Sepsis can also cause widespread vasodilation called from bacteremia. So now we have the infection causing the fever, which then causes sepsis, which then causes widespread vasodilation, bacteria in the blood, hypotension, major dehydration. As you can see, we keep going on and on, right? And patients kind of being intubated, or they can end up passing away because of this, and they're going to put on pressors. Viruses take over the metabolic process of the host cell and then use the cell to replicate. Also, some other not indicators, but other parts of sepsis or severe sepsis septic shock is the patient starts going into what they call MODS, M-O-D-S, which is a multiple organ dysfunction. And they also go into DIC and start throwing off multiple clots to the point where they start losing limbs. So as you can see, sepsis is dangerous, which is why we need to catch this kind of stuff early in the field. So many bacteria have a capsule that produces them from ingestion and destruction by the phagocytes. The presence of bacteria in the blood is also called bacteremia, which we already talked about. And you'll start seeing that bacteria in the blood more with patients that are septic. Bacteremia causes widespread vasodilation. And then your cells start leaking. Right. Immunologic and inflammatory injury is an inflammation is a productive response occurring in the presence of a cellular injury. It can be triggered by physical, chemical, or microbiologic agents. Signs of inflammation are heat, redness, tenderness, swelling, and pain. Imagine this though, okay? Everything we're talking about can all lead to a septic patient. If the inflammatory process is severe, systemic effects become evident. Patient feels ill, body temperature becomes elevated, the bone marrow accelerates the production of leukocytes, and you start getting leukocytosis. The outcome depends on the amount of tissue damage. All this as a whole, inflammation, redness, tenderness, there's an infection somewhere, elevated body temperature, leukocytosis kicks in. This all can potentially become septic to the patient as well. So this figure shows a systemic effect of tissue injury caused by various agents. Sepsis has a precursor prior to it. It's what they call SIRS, which is Systemic Inflammatory Response Syndrome. So if I go back a slide, we're talking about systemic response right here. So it kind of all blends into septic patients. So some injurious genetic factors. An abnormal gene may also develop by mutation of the gene during meiosis, by hereditary, or as a result of other causes later in life. Some genetic factors that may damage cells, obviously chromosomal disorders, premature development of atherosclerosis, or obesity. So more of the genetic factors. And as you can see also, obesity and other genetic factors and hereditary stuff is also important when you're doing your assessments. Because if you had history, let's say cardiac, okay, let's say they have acute coronary syndrome, they have plaque buildup. Let's say a male patient, 45 years old, develops chest pain, diaphoresis, ashen color, having a heart attack. You ask them their family history because let's say his father passed away at 45, 50 years old of a heart attack. His grandfather passed away at 45 or 50 years old of a heart attack. Hereditary, following that same path. Family history is almost just as important as getting a past medical history of that specific patient. Is this run in your family? Does diabetes run in your family? Does heart disease run in your family? Does cancer run in your family? Right? These are all very important questions to be asking patients when we do our assessment. We need to become more in depth. Obesity, malnutrition, vitamin excess or deficiency, mineral excess or deficiency. These are all different injurious nutritional imbalances, right? Which is why we need to make sure we do the best we can to stay healthy. Other physical agents or conditions would be heat, cold, and radiation may also cause cell injury. So the degree in cell injury is determined by the strength of an agent and the length of exposure. So let's put that into perspective. A patient who is out in the cold for a long period of time and it's 10 degrees below zero, what's going to happen to that patient? Okay, so break that down even more. Frostbite, hypothermia, what's going to happen to the body?
Starts to shiver to create heat.
Okay, that's a thermoregulator in your system causing shivering to create heat. Exactly. What happens when you stop shivering?
That's your central nervous system starting to shut down, isn't it?
Yeah. And your thermoregulators no longer regulate body temp. That's bad, right? These patients have, I'm drawing a blank here. These patients have core body temperatures in the mid to low 80s that are that hypothermic. And they run in different stages. And if you look at New Hampshire protocol, it states stage 1 through stage 4 hypothermia. And with that, they want you transporting to certain facilities. Interesting, right? They're saying that if a patient has stage 4 hypothermia and you're within an hour transport to a facility that has ECMO, is to transport that patient to an ECMO center to help oxygenate those cells and move blood around. Right? Portsmouth Hospital and Dartmouth and Lebanon are the only two in the state that have ECMO. That's it for the state of New Hampshire. Maine Med has it too, but obviously knowing New Hampshire, they're not going to tell you what Maine hospitals have. It's kind of like the whole diabetic thing. You're allowed to use New Hampshire maple syrup for a diabetic, but in Vermont, they use Vermont maple syrup, not New Hampshire. So, I mean, hey, so they kind of stick to the New Hampshire stuff, right? So you start breaking, like Evan just said, break down and shut down. That's exactly what's happening. Your body's breaking down and shutting down. It's no different than hyperthermia, same thing. Your body's going to break down eventually, and it's going to shut down because you're so hypothermic, or hyperthermic. And we have to start cooling these patients off. So we see frostbite, right? Hypothermia kicks in, or we start seeing heat exhaustion, heat cramps, heat exhaustion, heat stroke. And we get into more environmental emergencies, we'll cover this. So apoptosis, generally programmed into the cell as part of a normal development, we call it organogenesis or immune function and tissue growth. These proteins and DNA undergo controlled degradation and also allows their remnants to be taken up and reused by neighboring cells. With that, areas that have undergone apoptotic, my goodness, I can't speak today. Apoptotic death do not show any evidence of inflammation. So this can be actively or activated prematurely by pathogenic factors such as cell injury and inhibition to normal course of apoptosis also allows destructive cellular proliferation. Moving forward, as you can kind of see here, the cell and abnormal cell. Here you can see that you have immune system ineffective here, destructive of normal cells. Also going down to the immune system ineffective going into cancer. This kind of shows the process of cancerous cells develop. So you have a normal cell here, they develop into an abnormal cell, which then turns into a cancerous type cell, whether it be malignant or not. Normal cells start with the virus, radiation, chemical, carcinogens. They convert the cells from being normal to abnormal. So give me some chemical carcinogens that would lead your normal cell to go into an abnormal cell to start with creating cancerous cells.
Literally anything we come into contact with the firefighting service.
Exactly, right? Anything that you wear. And where are we seeing, since you brought that up, Ben, where are we seeing the most patients being exposed to these types of chemicals?
Where are they coming from?
I probably should rephrase the question. In which process of a building fire do we see this happening the most?
I see it, Kevin. You
Yes.
see it mop up. See it mop up when the fire's not going and it's smoldering.
Exactly. Overhaul. Exactly. So one of the things that we're supposed to be doing prior to taking our air packs off and overhaul is making sure that you have clear air quality. I don't look for department names, but how many departments out there that you know of actually take 4 gas meters, go up and actually go into these buildings and clear the air to make sure it's 100% clean in order for them to take off their air packs during overhaul? Kenny, never. They don't. You're right.
Depends
Okay.
on who's in charge of our fire. We do.
Yeah, yeah.
Some of
So
our officers really don't care.
but that's the thing, though, and this is why we do firefighter rehab, not because we want to hand out snacks and take blood pressures. We give these people the break that they need, for one, and 2, to make sure that they're ready to go back in. And then 3, incident command needs to step up and our operations and start clearing air before people take off their air packs. Another reason why during firefighter rehab, we shouldn't just be checking pulse oximetry. We need to be checking SPCO as well, right? We take off our air packs all the time. I am guilty of doing that when I was younger. Absolutely. It was always great to walk into a building fire during overhaul and take a big smell of that. It's like, oh, I smell that fire, you know? But in all reality, we're killing ourselves, right? No different than car fires. People not packing up for car fires. Oh, it's just a little bit of smoke. We can take that in, right? Think about the guys doing wildland firefighting, just the wood smoke itself. Granted, it doesn't have all the same carcinogens that are burning in the building. So we take all this kind of stuff, and I know this is not a fire program here, but yeah, exactly, London. You weren't salty if you didn't do that stuff. You're not wrong. You know, that's what happened. And that's why, you know, back in the day, they didn't wear air packs until 1981. NFPA actually required it, right? Looking at the different standards. So what they used to do is they just take their long mustaches, put them in their mouths. Now it's their filter. You know, that's what firefighting was back in the day. Where are those guys now? Right? So enough of that. Enough of the cancerous cells and my little spiel on wearing air packs and overhaul. Moving forward. All right. So necrosis is tissue death. So it's necrosis is the result of micro morphologic changes that occur following cell death. What else can cause necrosis? Can we, as providers, cause tissue necrosis and cell death?
Yes, from not cleaning your IV site.
Okay, and what else? You are correct, Sean, though, but keep going more with that IV. I think you blow a line. Exactly, infiltration. Then push deep in. Yes. Pushing sugars into a infiltrated line will cause severe tissue necrosis because sugar is very necrotic. However, sugar is phenomenal when it's inside the vein or inside the stomach or inside, things like that. But when outside of the protected areas of the arteries, things like the arteries, the stomach, the intestines, the brain, and it gets out into the interstitial space, it's very necrotic. I tell my EMT students this all the time. Your body needs 3 things to stay alive. What are they? It's kind of like the fire triangle. Move one, the fire goes out. Yeah, I'm old school. I didn't say tetrahedron. Sorry. All right. Fire triangle. Move one of the things, fire goes out. Body needs 3 things to stay alive. Remove one, the patient dies. What are they? Okay. Oxygen, blood, sugar. If you are missing any one of those 3, the patient will die. How hard can that be? Hypoperfusion. I'm talking about loss of blood. It leads right into it, right? Perfusion is the delivery of oxygen and nutrients, the removal of waste by the circulatory system, right? Hypoperfusion occurs when the level of tissue perfusion decreases below normal. In response, the body releases catecholamines, which would be epinephrine and norepinephrine, which produce increased strength of cardiac contraction, increased pulse rate, vasoconstriction, and increased systemic vascular resistance. Imagine that. All things are part of the sympathetic nervous system, right? Shock is an abnormal state of associated with inadequate oxygen and nutrient delivery to the metabolic apparatus of the cell. Inadequate state of tissue perfusion, resulting in the impairment of cellular metabolism and inadequate perfusion of the vital organs. That's why it's so important to make sure we perfuse patients. Oxygen, fluids, things that keep the body alive. Shock can occur as a result of inadequacy of the central or peripheral circulation. From a mechanics approach, 2 types of shock are distinguished. One is what they call central shock, which consists of cardiogenic and obstructive. Cardiogenic being the heart, obstructive being more of a drawing a blank with obstructive shock. Anaphylaxis, sorry. I think about that for a second. And peripheral, consider hypovolemic shock, and distributive shock like sepsis. So central shock, cardiogenic shock occurs when the heart cannot circulate enough blood to maintain adequate peripheral oxygen delivery. The most common cause is a myocardial infarction, a heart attack, an MI, right? So we got to make sure we're doing our 12 leads to see if the MI is there. Drawing our labs so that way the hospital has the ability to run a troponin. Troponins take about 50 minutes to an hour to get a troponin level back. So if you can run the labs and send them to the lab once you get there, it saves time. Most common, so the obstructive shock occurs when blood flow becomes blocked in the heart or great vessels. This is more of your obstructive shock. This is cardiac tamponade. As you can see here. So figure 8-9 shows a tamponade following myocardial rupture. On the left, distended pericardial sac. On the right, the pericardial sac is now open, showing clotted blood around the heart, which compresses the heart to prevent filling of the right ventricle in diastole. How would you be able to tell if someone's in cardiac tamponade? We've already covered this once before. What is the 3 things you look for cardiac tamponade?
Muffled heart sounds.
Muffled heart tones. Yep, there's one.
Blood pressure.
Yep. Well, ish. Narrowing pressures, narrowing pulse pressures. I see Tondra already put up the answer on there. Narrowing pulse pressures, so blood pressures, systolic and diastolic close together. So you're looking at, like, say, for example, like 90/86 for a blood pressure. And then jugular vein distension. What triad is that called? What is the name of the triad? The 3 things. Right, Beck's. Perfect. Good, good, good. Moving forward. There we go. So as you can see, the hematoma within the aortic wall on this one here. This illustrates the a thoracic aortic dissection. A tear in the ascending aorta causes proximal and distal dissections. And then B is a tear in the descending aorta which may cause extensive distal dissection as well. If you have a dissection and then it ruptures, okay, your aorta, if you think about it, is the diameter of a quarter, which is your major blood supply. Right? If cut off, you die quickly. Put in the fire terms. If you have an LDH coming in and you lose your water, you're going to die in the fire. Don't want to lose water. Get out, right? So same thing. That's your major supply of blood to the entire body. Peripheral shock is hypovolemic shock. Circulating blood volume is insufficient to deliver adequate oxygen and nutrients to the body. There are 2 types. Let's see. Distributive shock, widespread dilation of the resistance vessels, the capacitance vessels, or both. Moving forward to anaphylactic shock or anaphylaxis, which is histamine and other vasodilator proteins are released on exposure to an allergen. So histamine has different receptors. They're called H receptors. There are 3 types of H receptors, H1, H2, and H3. With these receptors here, we got to find a way to provide that histamine to stop being released. That's when you have ALS paramedics come on board. We give what they call Benadryl or diphenhydramine, and that's a histamine blocker. So your body wants to fight it, giving out histamine, but in turn also does more damage to your body. Septic shock, it results in a widespread infection. Neurogenic shock results in from a spinal cord injury. So as you can see in this one here, it shows you the difference between normal vessels and dilated vessels. As you can see, the pipes become bigger, therefore in turn drops your blood pressure. Your body can no longer maintain homeostasis with that, which is why we need to do vasoconstriction. What medication do we carry that we administer that causes vasoconstriction? What medication do we carry that's a sympathomimetic that causes vasoconstriction as an alpha 1? You guys will learn all this stuff here eventually. Epi 1 to 1,000, vasoconstriction, intramuscular injection 0.3 milligrams. So management of shock, most symptoms of shock are characterized by reduced cardiac output, circulatory insufficiency, or rapid heartbeat. To determine the presence of absence of shock, evaluate the presence of volume of the peripheral pulses, and assess end organ perfusion and function. We're going to look for modeling, pallor, peripheral or central cyanosis, and delayed cap refill may be signs and presence of shock. Decreased levels of end-tidal CO2 are an early indicator of shock. Early indicator. So again, how important is it to have end-tidal on your patients? Everybody should say very important, because you can tell a lot by looking at numbers and waveform. So here's MODS, MODS, which we kind of talked about here a little bit in sepsis, which is multiple organ dysfunction syndrome, MODS, is a progressive condition that occurs in some critically ill patients. So concurrent failure of two or more organs or organ systems that were initially unharmed. Respiratory, hepatic, renal, hematologic, neurologic, and cardiovascular systems are surveyed in diagnosing MODS. Overall mortality rate varies widely depending on the underlying etiology and ensuring diagnosis and treatments. Primary MODS is a direct result of an insult, such as a pulmonary contusion. A secondary MODS occurs when an injury or infection triggers a massive systemic immune, inflammatory, and coagulation response. Talked about DIC, that coagulation response, accompanied by the release of toxins. Secondary MODS is slower and more progressive organ dysfunction, right? That would be your septic patients that could have that. One of the most common causes of sepsis is what? What is the most common cause of sepsis? Infection. I'm seeing UTI, and you would see patients with urosepsis with UTI, but the most common cause of full-blown sepsis is pneumonia. And also one of the highest hospital-acquired diseases is pneumonia. Interesting numbers. So the body's self-defense mechanism is the immune system, which includes all the structures and processes associated with the body's defense against foreign substances. Some of the anatomic barriers would be decrease the chances of foreign substances invading the body. Skin, right? That'd be skin, hair, upper and lower respiratory tracts, acid in the stomach. These are all different barriers that our body has to prevent infection and different foreign substances entering our body. So the body's immune response, the body's defense reaction for any foreign substance directed against invading microbes, foreign bodies, and abnormal cell growth. The innate response starts first and is then reinforced by more specific acquired responses. So components of the cell wall, when active, the complement system, they activate the complement system there. So chromotaxins attract leukocytes from the circulation to help fight the infection. Leukocytes, white blood cells, right? Come in, help attack that infection. The complement cascade that ends with the formation of a set of proteins called membrane attack complex. All right. So types of immune system cells are the basophil, neutrophil, monocyte, lymphocyte, macrophage, mast cells, plasma cells, B cells, helper B cells, memory B cells, T cells, and killer T cells, right? All that stuff kind of fits in. So the natural native immunity is nonspecific cellular hormonal antibody response and operates the first line of defense against pathogens. All right, so moving forward. What you hear is to show how antibodies work. So antibodies make antigens more visible for the immune system in three different ways. Antibodies act as opsoins. In opsonization, an antibody coats an antigen to facilitate its recognition in immune cells by immune cells. So antibodies cause antigens to clump for easier phagocytosis, I should say. Antibodies then bind to inactivate some toxins produced by bacteria. So cell-mediated immunity is characterized by the formation of a population of lymphocytes that can destroy foreign material. And these are our subgroup of T cells. So remember, T cells help destroy materials, while your killer T cells, helper T cells, suppressor T cells, memory T cells as well. So these are our different T cells that help as a subgroup to come in and destroy that foreign material within your body. So the problem with that is that a patient who's immunocompromised don't have the ability to have these cells in the white blood cells to help fight off that infection. The way to find this stuff out is by running a complete blood count, and they give you all this information about these different cells that are available, and they tell you, hey, it's low. They can't fight the infection off. All right. So looking at that, give me one thing that would cause a patient to have low immune system? Yep. AIDS, chemotherapy, right? Things like that. Perfect. Good. This one here illustrates showing B cell activation. Again, I'll leave this up on the slide for you guys to look at. Very, very small. I literally can't read any of the words that are on here. But it's more of a B cell activation, immunocompetent B cells. This one here illustrates the interaction of cell-mediated and hormonal immunity. All right, so inflammatory response. We're getting close to the end here. So inflammatory reaction and immune response are independent processes that often occur simultaneously. The most common cause of inflammation and infection and injury with this as well. So acute inflammatory response involves vascular and cellular components, right? So we have that patient as anaphylactic. We start seeing that inflammatory response, which then in turn can cause shortness of breath, tachycardia, and also hypotension, right? Because we're getting that widespread vasodilation from that inflammatory response that we're talking about. That's when you start getting that vascular issue, which is why we give a patient epinephrine, because it has an alpha effect vascular, but it also has some beta effects as well, like beta 1 effects for heart rate, and it can also help with breathing with beta 2. So you're going to learn more about that when we start getting into the different alpha beta responses based on medications we're administering. So, so acute inflammatory response involves the vasculature and cellular components. So PMNs, they arrive at the site of the injury with a cellular component inflammation. So intravascular phase, leukocytes then move to the sides of the blood vessels and then attach to the endothelial cells. Extravascular phase, leukocytes travel outside of the blood vessels and then to the site of inflammation, and they start killing the organism. So the cellular event sequence that we're going to be able to see here is the margination, activation, adhesion, right? Then we see the transmigration and then the chemotaxis, right? That's our process that we're going to follow through. Cellular production would be the cytokines that are produced in the cells that affect the function of other cells, like monocytes release monokines, lymphocytes release lymphokines, and right down through. So we start seeing that inflammatory response, and in hopes that we can see reduction. of the area that's inflamed, or depending on whether or not be full body widespread inflammation or more localized. As far as injury resolution and repair, normal wound healing involves 4 different steps: repair of the damaged cells, removal of inflammatory debris, restoration of tissues in a normal state, and regeneration of that cell below it. Wounds then heal by primary and secondary intention. Primary intention occurs when clean wounds are opposed to margins, and secondary intention occurs in large, gaping, or infected wounds. Some factors that lead to dysfunctional wound healing may be local or systemic. Some of your local factors include infection, inadequate blood supply, or foreign bodies. Your systemic includes inadequate nutritional intake leading to insufficient levels of collagen, anything that interferes with the epithelialization or wound contraction, hematologic abnormalities, diabetes, AIDS, and the use of corticosteroids. Chronic inflammatory response is usually caused by an unsuccessful acute inflammatory response associated with infiltrate or pus containing monocytes and lymphocytes, and usually involve tissue destruction and repair or a scar formation. As you can see illustrated here. How are we doing? You doing good? You guys need a break at all? We have 19 slides left. Do you want to just power through it, or do you want to take a break? I'm seeing power through. All right, I like it.
Send it.
Send it out. I love it. All right, moving forward. So the variances in immunity and inflammation. As you can see, there's 4 different types. So hypersensitivity is any response to the body, to any substance to which a patient has increased sensitivity. Imagine that, allergic reaction. So allergy is a hypersensitivity reaction to the presence of an agent. Autoimmunity is a production of antibodies or T cells that work against the tissue of one's own body. Isoimmunity is a formation of T cells or antibodies directed against the antigens in another person's cell. Types of hypersensitivity reactions would be immediate hypersensitivity occurs in response to a stimulus, or degree of severity varies with this. There's type 2, which is cytotoxic hypersensitivity reaction, which your cells are then destroyed by complement fixation or other antibodies. Type 3, which is tissue injury caused by immune complexes, which may be systemic or localized. Systemic form of serum sickness, which then results from a large or a single exposure to an antigen. Or localized form is an Arthus reaction. And a type 4 is a delayed cell-mediated hypersensitivity. There are 2 types in that one there: delayed hypersensitivity and cell-mediated cytotoxicity. So as you can see, this is a type 1 allergic reaction. Right? So the immune system then targets different molecules depending on the type of hypersensitivity reaction. An allergic reaction is a target of an antigen or allergen, with this one here. An autoimmune reaction is the target is a person's own tissue, like Graves' disease, type 1 diabetes mellitus, rheumatoid arthritis, SLE. Other immune deficiencies or immunodeficient body immune system is inadequate, and resistance to infectious disease is decreased. This can be congenital or acquired. Congenital immunodeficiencies are patients that have inherited defects that involve a lymphoid stem cell. Some acquired immunodeficiencies would be like nutritional deficiencies, may depress bone marrow function and diminish the white blood cell development. This can also be caused by trauma. as well. Treatment-induced immunodeficiency is caused by medications like chemo, chemotherapy, and then replacement therapy is available for immunodeficiencies as well. So again, you need to talk to your patients, find out what medications they're currently taking, and find out if they're immunodeficient, right? Make sure they're wearing a mask, make sure you're wearing a mask, and prevent any type of infection getting into them the best you possibly can. Some other factors that cause disease would be genetic, environmental, age-related, and sex-associated factors that can cause or contribute to the disease itself. Uncontrollable factors would be genetics and race. Controllable factors would be smoking, alcohol intake, inadequate nutrition, lack of physical activity, and stress. So the analysis of a disease risk involves the consideration of a disease rates and disease risk factors. So some casual factors, risks are factors that directly cause a disease to develop. There's non-casual factors, which risk factors that are associated with a disease, but not a direct cause. And with this, all studies of diseases should consider the incidence, prevalence, and mortality of that disease. Remember the risk factors of age and sex differences often interact as well. So some common familial diseases and associated risk factors. So a true genetic risk is passed through generations by inheritance of a gene, which we already talked about. We already discussed this as well earlier in this lecture, that we need to make sure we're getting that family history when we're talking with our patients. Diseases with familial tendencies seem to cluster in a family group despite lack of evidence or heritable gene associated with abnormalities. And immunologic diseases are also caused by hyperactivity or hypoactivity in the immune system. This illustration here shows the pathogenesis of an allergy. The next one is common risk factors with cancer. Describes the pathology associated with malignant growths. And then diabetes mellitus was one of the most significant endocrine diseases, is diabetes. You have hematologic disorders like hemolytic anemia, which is characterized by an increased destruction of red blood cells. A disorder of as a number of causes, such as Rh factor blood transfusion reaction, a disorder in the immune system, and an exposure to bacterial toxins or chemicals such as benzene. Hemophilia is an inherited disorder characterized by excessive bleeding, right? And they're the ones that are lacking in different factors as well. One of the blood clotting proteins necessary for normal blood coagulation is absent or present in abnormally low amounts. So they're going to be taking, I want to say it's like factor 8 is one of the factors that they're missing within the hematologic disorder for hemophilia. Hematocritosis is an inherited disease by which the body absorbs more iron than is needed. Patients that have hemophilia, they are hemolytic anemia, a lot of times they have history of or they actually know they're hemophiliacs, right? Another important, thanks Rosa, another important factor to this as well is if you have a patient that's a hemophiliac and they're involved in a motor vehicle accident, do a very, very thorough assessment of these patients to look for any abnormal bleeding. Blood pressures every 5 minutes. Cardiovascular disorders like cardiomyopathy, which is a disease of the myocardium. And I'll show you guys how to look at left ventricular hypertrophy on EKGs. I know it's above your scope, but it's good information to learn as we move on. Mitral valve prolapse, coronary heart disease, hypertension, and stroke. are common risk factors. This illustration here shows the hypertrophied, I should say, intraventricular septum. This is normal here. As you can see, it's gotten bigger. So a lot of times they call this the hypertrophy or cardiomyopathy. So the hypertrophic cardiomyopathy is almost like a floppy heart. So as the heart is pumping, the left ventricle is floppy enough that it doesn't push out all the blood. All right. And what you'll see is very, very tall QRS waves. And if it's greater than 35 millimeters, by adding 2 of your vector leads together, the patient has LVH. Again, cardiology. We'll get into more of that later on in the program. Other renal disorders would be gout and kidney stones, as you can see here. Gastrointestinal disorders, almost there. So malabsorption disorders, lactose intolerance, ulcerative colitis, Crohn's disease, peptic ulcer disease, gallstones, and obesity, which is a body mass index of greater than 30 kilograms. Not greater than 30 kilograms. My goodness, that'd be huge. That's small, I mean. So it's a larger body mass. Neuromuscular disorders like Huntington's disease, muscular dystrophy, multiple sclerosis, Alzheimer's disease, or more your neuromuscular. You have psychiatric disorders. Some common psychiatric disorders have a familial or genetic component, like schizophrenia or bipolar disorder. If anybody ever wants to have a thought of what being schizophrenic is like, YouTube actually has a schizophrenic, I'm not going to say a test, but more like I'm going to say it's like not even it's like a recording. What they ask you to do is close your eyes, listen to this video, this video that's playing on YouTube of schizophrenic disorder, and try to gather 15 different thoughts of what you want to do, like a grocery list or something like that, while listening to all the different voices going on. And they can show you that it makes it very difficult. That's a patient that's schizophrenic. So it's pretty interesting process if you take a look on it online through YouTube. Stress and disease process here. Stress includes a wide range of strong external stimuli, psychological and psychological as well, that cause psychologic response. So psychologic stress is a change that makes it necessary for the cells of the body to adapt. Some concepts related to psychological stress include stressors itself, the effects in the body, and the body's response to the stress. The general adaptation syndrome has 3 different stages. Stage 1 is when the body reacts to stress first by releasing catecholamines. Stage 2 is resistance and adaptation, where the body then adapts to the stressors primarily by stimulating the adrenal gland to secrete glucocorticoids and mineral corticoids as well. So the anterior pituitary releases a hormone called ACTH. And endorphins are also released as well. Then you have stage 3, which is exhaustion, where the adrenal glands become depleted, decreasing the blood glucose level, resulting in decreased stress tolerance, progressive mental and physical exhaustion, illness, and collapse. As you can see here in this slide, it's a response to stress and how it releases through the hypothalamus and the pituitary gland, releasing ACTH and the nerve signal through the medulla and the cortex, adrenal glands as well, releasing into the kidneys, working its way down to the fight or flight response, right? So all this happens. The fight or flight response, what you're seeing here is the sympathetic nervous system reaction, right? Increase to energy storage, body metabolism speeds up. You have an increased heart rate, breathing rate, blood sugar. All this stuff starts to increase, in response to the sympathetic response of the nervous system. All right, so almost done. 2 more to go. This shows how the stress triggers secretion of the adrenocorticotropic hormone, which releases in cortisol secretion. And to finish up, the effects on chronic stress, as you can see here, hypothalamic pituitary adrenal axis controls reactions to that stress. So continued stress leads to the loss of normal control mechanisms of the hypothalamic pituitary adrenal axis. Adrenals then continue to produce cortisol, which then exhausts the stress mechanisms, leading to fatigue and depression, and interferes with serotonin activity. A consistently high cortisol level suppresses that immune system, and then you start getting coping mechanisms which play a role in the physiologic response to stress. So effective coping mechanisms can help a patient improve that immune system response. So it's very important that we take care of the stress that we're under, but also understand that if you have a patient that is chronically stressed out, it's putting a lot of stress on that body to not meet that homeostasis that we were talking about, right? And then also leads to increased depression, suicidal ideations, or potential for homicidal ideations as well. So understand that process, and we got to get this patient to help relieve that stress. By doing so is getting a patient to the hospital to speak with social workers and things like that to help them get on the right medication regimen to fix it. All right, let me just shut the record. Oh, my goodness.